So today I'm going to walk through a very important step to CK topic, which is cardiogenic shock, and most importantly, how to differentiate cardiogenic shock from other types of shock. So let's delineate the whole process properly. So we have a 68-year-old man who is brought to the emergency department. He has some risk factors like hypertension, type 2 diabetes, and hyperlipidemia. He also has a history of chest pain that is can be due to angina. The patient is pale and diaphoretic. The blood pressure is very low. Patient is tachycardic, and oxygen saturation is low. On examination, the extremities are cold, jugular venous distension is there, and bilateral lung crackles are there. On auscultation, S3 gallop is there, and ECG shows ST segment elevation. So the shock state shows that lactate levels are increased. And the question is, what is the most likely hemodynamic profile in this patient? So if you are thinking that B is the right option, you are correct, because this is a very classic case of acute myocardial infarction complicated with cardiogenic shock. So NBME actually loves the pattern recognition, and if you understand hemodynamics instead of isolated concepts, these questions are going to be very easy for you. So actually in cardiogenic shock, what's the main problem? What's causing cardiac output, decreased cardiac output? So let's delineate this process that the main problem in cardiogenic shock is pump failure. And because of that, our cardiac output is going to be low, and it's going to reflect in the form of decreased peripheral blood perfusion. And because of that, we are going to have cold extremities. That's an exam clue. And because of pump failure and low forward blood flow, our blood is going to back up into the lungs. And we are going to have wet lungs with pulmonary edema, and it will show in auscultation in the form of crackles. And that's why having crackles and cold extremities are the two clues towards cardiogenic shock. So cardiac output is actually equals to heart rate multiplied by stroke volume. So during myocardial damage or pump failure, our stroke volume is going to decrease, which is going to reflect in the form of decreased cardiac output. And to decrease cardiac output, and it's going to reflect in the form of decreased blood pressure. And our body will compensate mean arterial pressure by increasing systemic vascular resistance when there is already decreased cardiac output. So that's why our systemic vascular resistance is increased in cardiogenic shock. Yes. So the elevated PCWP is because of low forward blood flow and increased systemic vascular resistance because of compensation by our body to increase mean arterial pressure. And systemic venous oxygen saturation is decreased because that in cardiogenic shock, tissue perfusion is low and tissues are hungry. They are going to extract oxygen drastically. That's why our systemic venous oxygen saturation is going to be low in cardiogenic shock and hypovolemic shock. So now let's have a look on distributive shock. In distributive shocks, the main problem is decreased systemic vascular resistance, and that's why our vessels is going to be dilated and they are going to dissipate heat. That's why we are going to have warm and flushed skin. And because of decreased systemic vascular resistance, our diastolic pressure is going to be increased, as pulse pressure is equal to diastolic pressure minus systolic pressure, and diastolic pressure is increased. That's why we are going to have increased pulse pressure, increased cardiac output, and it is going to reflect in the form of bounding pulses. In obstructive shock, the problem is obstruction. In massive pulmonary embolism, the obstruction is at the level of pulmonary artery, and that's why our right heart pressure is going to be increased in the form of jugular venous distension, but left heart pressure are going to be decreased. Yes. And same in the case of tension pneumothorax, that intrathoracic pressure is increased. There is impaired venous return in the right heart. That's why we are going to have jugular venous distension because of backup of blood in jugular veins. And the blood is not moving forward from the right heart towards the left heart, and we are going to have decreased left heart pressures. But this is not the case in cardiac tamponade. In cardiac tamponade, In cardiac tamponade, fluid is actually compressing both chambers of heart equally. And that's why we are going to have increased right heart pressure in the form of jugular venous distension and increased left heart pressure in the form of pulmonary capillary wedge pressure. The only obstructive shock with increased pulmonary capillary wedge pressure is cardiac tamponade. So, the most important examples of cardiogenic shock are whenever you are having a patient with MI, pulmonary edema in the form of crackles and hypotension, this is cardiogenic shock until proven otherwise. And jugular venous pressure and crackles on the lungs are going to show that filling pressures are elevated. Extremities are cold because of low tissue perfusion, and lactate is elevated because hypoperfused tissues cannot undergo aerobic respiration. That's why they are going to have anaerobic respiration and produce a lot of lactate. So first line vasopressor in cardiogenic shock is norepinephrine, and if the hypertension is refractory, we can add dobutamine. And definitive treatment for cardiogenic shock due to MI is revascularization either via PCI or CABG. Yes, so this was our cardiogenic shock, and now we can differentiate cardiogenic shock from other types of shock. And the key to differentiate these shocks on exam day is to understand the physiological patterns instead of memorizing isolated concepts. Once you understand hemodynamics, these questions are going to be a piece of cake for you on the exam day. Thank you, and let's meet you in the next video.